All right. Well, thank you folks for joining us today for another Spotlight Analytics demonstration. Today, we're going to be diving into the outcomes focused side of the Lown data set that we have built into our platform. I'm Lynn, and this is my colleague Dave Delano here. Hey, everyone. All right. So Dave, do you want to go ahead and just give us a brief overview about Spotlight as a whole, some of the ins
Sure.
and outs?
Sure. Yeah, happy to do that, Lynn. And my name's Dave Delano. I'm a senior director here at Mass Health Data Consortium. Lynn and I oversee the Spotlight Analytics work that we do here. Denny Brennan, our executive director, is unable to join us today. He's in the this is the Weedy Spring Conference Week, so he's over there hosting a number of meetings there. But we're pleased to have everybody join today. Thank you all. As Lynn mentioned, this is a very small group, so at any time, just stop us, ask questions, raise your hand, come off of mute, do whatever you wish to do to gather our attention, and I'll continue to monitor also the Q&A and chat windows as well in case there's any questions there. So as Lynn said, just to give you a quick overview of the Spotlight Analytics platform, this is a data analytics platform that we've been working on for many, many years. The idea of it is that we collect data from a number of sources, and you can see the data sources here through the CHIA data set, which is the state of Massachusetts hospital information data set, Rhode Island Department of Health, CMS/Medicare, and most of that data, some of that data feeds into the Lown data, which we'll be focusing on today, the Internal Revenue Service of all things, and then the HCRIS, which is the cost reporting information system. So many different data sources feed into Spotlight Analytics, and then we work with our development partners to create what we believe are industry relevant views of data and also analytics capabilities to drill into different views and different sets of data depending on what someone's interest area may be. The platform is based on a Tableau user interface tool, which Lynn will be demonstrating for you today. And as we mentioned, there's a number of data sets in there already. Massachusetts and Rhode Island hospital case mix data. We were just informed that we'll be getting an update to the CHIA data set, which is will be the 2022 data set. We're always in arrears because the data has to be collected, sent to us, and then uploaded. But it gives a historical perspective over time. The case mix data shows really market share and volume around specific. You can drill almost down. Really, you can drill down to the specific case type you're looking for, whether that's inpatient. There's obviously different measure sets within inpatient. We have hospital data for Rhode Island that includes emergency data or outpatient as well, and then the Lown data itself, which is if you're familiar at all with the Lown Hospital Index, you can go to the website and search for Lown Hospital Index and see a little bit more about what that data comprises. But it's really different measure sets focused around equity, value, outcomes, and quality across those dimensions. And today we'll be focusing specifically on outcomes, health outcomes view of that data. So next slide, Lynn. So what are the benefits? I mean, for your organizations, many, we believe. I mean, obviously, we're strong believers in it, but obviously things like strategic planning, trying to figure out market share, but market share in relation to some of the things we were just talking about, like outcomes, for example. So you may have, the best market share in a particular area within your organization or your service area for a particular facility or hospital service area. But what you may find is, though, that outcomes can vary depending on, in relation to those volumes. You could be seeing, volumes going up in a particular area, but satisfaction declining, for example, patient satisfaction, or the opposite. Patient satisfaction is increasing, but volumes may be declining. So for things like strategic planning and that we're finding a lot more people now using us for annual reporting needs for things like their annual reports, particularly as it relates to more, as we get more and more into health equity and health equity analysis and some of the sort of improvement areas that folks are looking for around just general operational awareness, community benefit analysis, financial analysis, and other use cases. It really kind of, the list goes on and on of the things you could potentially do with the data. But we, we tend to see those types of uses most frequently. It is secure, HIPAA compliant, web-based. Obviously, it's through the Tableau interface, as we mentioned before, with very sort of intelligent drop down and point and click, and Lynn will demonstrate how that looks today. Use case there for being able to navigate through the data with different filters and dimensions and views of the data. Secure, as I mentioned, we host it in the AWS cloud hosting environment, and we're compliant with HIPAA and all the other privacy regulations within Massachusetts, and we sign confidentiality agreements with CHIA and our other data sources. The notion is that there are some sample data sets that include ICD code data, and there's this thing called small cell suppression. So if there's fewer than 11 particular instances of circumstance within a service area, then we suppress those views, because it can be sort of interpretable, if you will, that there's a small cell size within a particular zip code area. So we do things like that to protect privacy. There's a simple sign-up license agreement subscription model, which is based on organization size generally, so depending on the hospital or the organization size. So we scale it accordingly, all the way from small all the way up to the largest. Very easy to sign up. There's no legal complexity. There's no data use agreement complexities with CHIA that people have to go through. And really all the infrastructure is on us. So it's purely web-based. And I mentioned the fair sliding scale pricing model based on net revenue is generally how we do it for the Spotlight platform. So with that, I'll hand it over to Lynn, but obviously as I said before, if there's any questions, jump in.
Yeah, and just to kind of go back on that, sorry, that second to last point there is a big one. We see a lot of our customers and organizations come to us specifically for this. You may or may not, but if you may or may not know, but if you've ever tried to go through the state or many state agencies to get this data, a lot of them will tell you it's about a several month time frame just to even get started. Now, some of them may be quicker or whatnot, but timelines haven't necessarily improved, especially ever since the pandemic. Everything seems to be kind of still backlogged to some degree. It's getting better, but yeah. So this is a big one that we see a lot of folks that either can get it for somewhat of a discounted price because they're have some sort of agreement or association. It's sometimes easier just to go through and have it already set up. And our system is essentially turnkey, as you'll see in a minute. So you don't need to go ahead and apply, get approval, which, who knows how long that will take. But according to the government agencies, it could take up to 90 days. So, if you need some data quick, that's probably not the route you're going to go. And then once you do get the data, it is a massive, massive file of cells that you're going to have to then interpret or stand up some sort of platform to be able to read or pivot this data into some sort of usable fashion. So just all that to sum up, basically, it's a turnkey with us. If you wanted to start today, you in theory could. We could sign you up, sign the agreements, and get you credentials. So it's simple as that. But so not to sound too pitchy there, didn't mean to, but I really can't stress that enough how easy that is to make it for folks, because the people that are using this is better healthcare, right? So we do have some use cases for example. I know Cambridge Health Alliance is a big advocate for us, and they've used this to streamline some of their locations and either use it to transform something that was a emergency department outpatient center into a urgent care. So it just depends on the use cases, and you can use the case mix to see your volume, see the areas that are either underserved or maybe even potentially oversaturated, and see where there's some opportunities there. So it's a lot of good insight, helpful insight. So, but any questions before we move forward or jump into this about our discussion today? All right. So let me tell you a little bit about the two different data sets from a high level perspective. So we have the CHIA and Rhode Island hospital case mix data. As Dave mentioned, this is hospital discharge volume and encounters. So naturally, it's historical, being that it's last year's data and the years prior. And actually, to that point, we're getting the fiscal year 2022 in the next week or so. So we imagine that we'll have that in ETL and into our system probably by mid next month, assuming all goes well with the quality and analysis there. So we'll double check, but everything should be set to go there. So right now we have inpatient emergency observation. That's for the CHIA side. For Rhode Island, we only have the inpatient and emergency. They don't collect observation data. That's not mandatory reporting in Rhode Island. So it sort of is what it is. We'll take what we could get, but we have essentially level 4 data that goes almost essentially down to everything other than the exact date of the visit, the hospital visit, because we don't see necessarily a need for that. That's really draws a line between the whole nother use case. So when you're going that far, you're really getting into the PII and potentially identifiable patients there. But so we have about roughly 37 total high level dimensions. Each one of these have many other few 2 to 3 attributes that kind of roll up into them. And then we also have measures, which are essentially flag values that you could drop in to give you such things as average length of stay for what you're trying to filter upon. For certain ICD-10 code diagnoses or procedure code or set of procedure codes, you can go ahead and find that out, drop those in. So some of them that out of the roughly 46 total that we have here, some of the representative or sampling uses here that many of our customers commonly or typically use.
Yeah, I'll point out, Lynn, these are just samples of the types of dimensions and measure. There are more of all of these. This is just a representative sample.
Right. So, and here is, we're not going to necessarily go into the case mix data, but just want to give you a visual of what you would see if you were to log in. This is what the custom dashboard would look like. So do you see my mouse here?
Yep.
I think. Yeah, okay. So on the left-hand side here are the dimensions that I mentioned. So here under hospital hierarchy, you can either filter it by system, a type of hospital, or the hospital itself. So, you know, or all of them, depending on what you're looking for, what type of report you're trying to set up. So you can, all of these are filterable. We have the ICD-10 codes that go very far down. And if you need something that's highly customized or for a very specific use case, we're not unknown for this. So if you need help with something, you know, we're very much a kind of hands-on white glove touch experience where if you need help, we could go in the back end and help assemble a report if there's something specific you need to get out of. Obviously following HIPAA and all of the compliances to get you what you need. So, because sometimes it's difficult to assemble a report just based on this view if it's a very complicated or intricate report or measure that you're trying to do. So, on the bottom here, you have the different measures. As I mentioned, you can just drag and drop these in here, and they will basically split up that value for what you have filtered. And then speaking of filter, these are the values that you can check off or uncheck. So yeah, just a very simplistic view. And you can, of course, if you're familiar with Tableau, then this looks familiar to you. You can, arrange this how you want the report to be displayed, in relationship to columns and rows, etc. So today, let's get into what we're going to talk about. So today, we're going to be talking about the Lown Institute data. That's what we're going to be focused on. If you're not familiar with Lown, as Dave mentioned, they are sort of the local heroes that are advocating for the patients and for better healthcare as a whole. And they are doing this through the lens of accountability with the aim of, equitable healthcare across the country. So this is not a Massachusetts or even a New England index or ranking system. They have all the hospitals that are reported on ranked. So you can go on their website and look at the high level of this. However, if you look on this chart here, this little chart we kind of made, the ones in blue are specific to what we have in the system that you can drill down and look at each of these ranks to kind of give you a better view instead of a 30,000 level view of what is going on that goes into this ranking. So today we're going to be looking at the outcomes. So this involves clinical outcomes, as well as patient satisfaction and patient safety, really, too. So we'll pick a few of these examples to go through and take a look at real hospitals with the real rankings, see what they are today, and see what we can sort of infer from them. Now, keep in mind, this is sort of a outside view in. So is it going to tell you the whole story? Not necessarily, but it's definitely a good starting block and a foundation of where to go as a guidance and a tool to look at any of the variables and variances to see what is going on that, basically account for that ranking. So any questions so far? Feel free to, you guys have us for this hour, so please, it's a very intimate group. Feel free to go ahead and unmute yourself and just chime right in. So, okay. I won't read all these to you, nor will I make you read these, but as mentioned in the blue, so some of these are what is called or known as tier 4 measures. So they get into a very specific ranking and measure of these attributes that go into the overall outcomes measure that you would see on the website. So you cannot get this information from their website. We have an exclusive partnership with Lown, so we're able to go ahead and provide this to you. And really, if you take a step back for a moment, using this data as well as the case mix data, you can sort of take a guess or see where our goal is in this sort of triangulation of healthcare, right? We're trying to see how, things rank, how organizations, where things stack up, and then also sort of the, albeit historical view of what are the values, how much volume, what is happening. It's sort of the what is happening, even though it's historical. We would love to get to real time. But as far as I'm concerned, I don't think there is such a thing that exists quite yet. We haven't gone there. And even all the fine folks over at the WEDI conference are essentially trying to push the needle forward on that right now as we speak. So that's the
I'll
sort of goal
just
here.
add one dimension to the conversation, Lynn, which is that we're also looking at much more in depth social determinant and equity related data as we go forward. We understand, equity is becoming a very hot topic these days. If folks aren't aware, yeah. I think CMS has coined it equity by design or something of that nature. They've got their buzzwords, but essentially what it means is that everything we should do should have that lens on it, essentially. So even as we're looking at patient satisfaction and outcomes, we should also be looking at equity, and we should also then be looking at, as Lynn pointed out, at market share. So the sort of the the triple aim of healthcare, if you will. And so we're spending a lot of time looking at equity data right now. We actually do have Z code data in our data set. And as folks know, the Z codes are being heavily looked at right now for social determinant and equity related measures. And we've actually done some sample reporting of that data in our data set, and likely will be adding that overall high-level dimension view to the Spotlight analytics going forward.
Mhm. And let us know if folks are interested in this. We can do another sort of deep dive or demo on just that specifically, because those Z codes that delve into the socio-economic side of things it's fascinating just to poke around and see what is in there. And
Yeah.
yeah, it's very interesting. So definitely a hot topic for sure. So,
Mhm.
especially when it comes to sort of the regulations and reporting that are being rolled out in Massachusetts, actually. So it's very relevant.
Yeah.
And we'll dive into this in a second here, but this is what you will be seeing in just a second. It is a snapshot of when you first log in, what you would essentially see. Same setup, however, it's a little separate. They're not called dimensions. These are the individual measures on the side here. You can still filter them. And then since they are measures, they essentially will spit out a value, in most cases, a rank or a star value, some of the different grading systems that the Lown Institute uses. So you'll be able to assemble your view here. So I'll go into this as well as some other features and other views we have. So let me go ahead and switch over. And while I do that, any questions so far?
Yeah, right. I was going to say,
Commentary? I
while
mean, yeah.
Lynn's logging us into the live demo, if there's any comments or questions, feel free.
Right here. Sorry, just had to log in. Okay. Can you see my screen, Dave? Okay,
Yep.
everything here?
Yep. Looks
Okay,
good.
perfect. Right, good, good. So as mentioned on the left-hand side column here, you have your expanded different measures. So community benefit, inclusivity, all of that equity, health equity side is very important. So you could assemble your view, your report, how you want to. I mean, today we're going to be focused on the outcome side of things. So outcome, clinical outcome, patient safety, patient satisfaction. But that doesn't mean you can't, do a cross section of this along with some other factors such as different measures of equity and see how those play, if they do play a part in those rankings or not. So
Yeah,
go
I'll just
ahead
point out,
and
let me just
yep.
point out that the equity measures we have here, Lynn, are mostly like community benefit equity. If you look at the
Pay equity,
yeah, pay
yeah,
equity, things like that. Yeah, it's not so much healthcare delivery
health.
like Z code,
It's
equity in
not so
that
much
sense of the word.
SDOH. Yeah,
Right, right. Yeah, so that's just a something to be aware of as we talk about these terms pretty freely. Equity as defined here is more around sort of institutional community benefit and things of that nature.
right, exactly. How the hospital is serving in an
Right,
equitable way, whether it's payment or inclusivity, whether it's how much of their patient base is different education levels and communities, that sort of thing.
right,
So it dabbles into it in a high level.
right,
Right.
right.
Yep. So let me go ahead and so first we're gonna set up. We don't necessarily need the hospital referral region, but it's separated into the kind of four quadrants as you would imagine Massachusetts is. So for now, I'm just gonna go ahead and hide that, make this a little bit more readable. And let's go ahead and drop down and show, we'll see if we want to filter any hospital systems in particular, or maybe just by hospital. So you could go ahead and narrow this down to, say you're looking at something in sort of the Boston and South region, then you could go ahead and choose those particular hospital systems or individual hospitals that you want to compare and rank against. So maybe Berkshire is not relevant in your scenario. So, to hide that, go ahead and uncheck that, right? So, but
So let's ask,
just to
does
point that out.
anybody have a particular hospital or hospital system they're interested in? Feel free to
Yeah.
offer one up and we'd be happy to bring it up.
Or if anything jumps out at you. I mean, so we're going to look at outcome here. So why don't I go ahead and put, so we have our outcome rank. Let me go ahead and put some other measures in here. Let's see what clinical rank shows up as. I don't know if any of these will surprise you, but oh, right now everything is sorted by alphabetical order by hospital system, as you can see here. So some of you may already guess that, but I figure I'd point that out. It's not sorting this in this particular view. But
right. At this high level view, I think that's the way that sorts because of the nature of the data.
right. And you can, there's so many ways that you can slice and dice this. So this is just sort of one example. But, you know, in this view here, you can do a lot, hence the name, custom dashboard. But so I'm dropping in the 7-day inpatient readmission just to kind of see how that falls in line here. Like, I'm just gonna click one here. So for instance, here you could see that the overall grade is A, which is good, very good for Massachusetts. And it is ranked 50 on the outcome. So not favorable, not really favorable at all. And I'm not singling this out. This is just happens to be just one I mouse around it. But the clinical outcome rank is 22. So that's fairly in the middle, somewhat above average middle. So just shy of above average middle. And they're ranking 31st on the 7-day readmission. So it could improve, but also could be very worse. The equitable rank and the overall equity rank is sort of middle road as well. That's pretty good. But the value, not so good. And value is a whole nother sort of topic. We covered that on our last one, but things that go into value is not maybe not what exactly it sounds, but it's more the sense of overuse or avoidance in some of the common overprescribed or over procedures that hospitals may or may not practice and engage in. That's how it's being ranked. So let's drop a few other ones in here. So if anyone sees anything they like, please feel free to call them out. But we'll drop in the 30-day mortality rank. And then how about maybe we'll do this one. And this is a central line associated bloodstream infection. So we'll see, you know, if this has anything to do it, or surgical site infection have anything to do with this sort of clinical outcome rank. So outcome is, remember, so for this hospital in particular, the outcome rank is not great by any means at all, really. But this is not anything about the hospital itself. It's just, this is what the data shows. It is what it is. It's just an insight sort of from a 30,000-foot view, going closer and closer sublevel as you add these different measures to kind of get a better picture of the whole story. Now, only I think maybe perhaps, you know, with both sides of the coin from inside and the outside view, would you be able to know as to why this number is what it is. Right?
Yeah, and I live
not.
actually, I actually live in Berkshire County, and I know Fairview Hospital pretty well. And
Oh,
not,
good.
like you say, not to disparage any of the work they do there, but they do deal with a very for sort of aged population. A lot of times people are coming in and out of nursing homes to Fairview and then back out again. And so sometimes they come in already with complications there. So it's very, yeah, you have to have certain amount of understanding of the essentially the risk profile or risk stratification of the patient population sometimes when you look at some of these measures. But what it does tell you, though, is in relation to other facilities, like you would probably want to compare them to Berkshire Medical Center just above them to see their overall composite score with Lown is A. So they're doing well overall. That's the composite ranking for the facility. But then as you dive into some of these outcome measures, you'll see the reflection of the case mix and the types of populations that they're serving. And you'll see that across a number of these.
Look at that. So kind of,
Right. A lot of
That's high
readmissions.
as well. Yep,
Yeah,
exactly. So,
a lot of readmissions because, like I said, sometimes people are in and out of nursing homes, back to Fairview, back out to the nursing home. So, very often there's lots of complications associated with this population.
right. And even I think I do remember if you in the case mix side, there is a well, it's under the disease trend report there, but what it does is it gives you sort of the top DRGs,
Hmm.
diagnosis groups, and you can see a lot of them are for Berkshire in that region are hip surgeries or knee
Right,
surgeries. So
exactly.
it dominates that region, and the only reason I know that is because it jumps out at you when you go look at that page.
Yes,
So it's a good
absolutely.
point. Yeah,
Yeah,
yeah.
absolutely.
You sort of have to know
So,
the
yeah,
locality and yeah.
yeah.
But it's a good comparison tool. And if you didn't necessarily know that, it's still a good comparison tool to use that to leverage. I know I don't want to put this in sort of a business advantage way, but you could use this in a way that you could build either strategic partnerships or such. You could kind of
Hmm.
call that with other institutions to either work together or have some sort of agreement for better or for worse based on how people are performing, how organizations are performing. So,
Yep.
conversely, you can use that to go back to them and say, so, you're not ranking so well on this. We'd like to go ahead and either have some discussions about this. If we're going to be have an agreement that we're sending our patients to you, you're going to be sort of our outpatient care that or send inpatient care there.
Mhm.
You may want to know these kind of things and just see where these hospitals and their value where they stack. So there's many
Well,
different use
and
cases.
to our earlier point about strategic planning, it certainly gives the opportunity to say, well, because we're having sort of this 30-day mortality rank of 49, as I said, is, that I think there's what, 55
55, yeah, I believe
hospitals. So this is
55.
49 out of 55,
Yeah,
30-day
you're in the
mortality.
bottom,
Yeah, I
very
mean, but it's
bottom.
again, it's what I was just saying before, when you look at the demographics of this community, it makes sense, just there isn't a lot they can do about that. But it is certainly gives the strategic planners and the clinical people something to think about. Like, how do we improve these numbers given the population we're dealing with? Where are the challenges? And then therefore, where are the opportunities to, focus resources and time and attention?
Right.
Yeah.
Well, let's add another interesting dimension. What about when it comes to patient satisfaction? How about nurse communication? So maybe we can't help what their clinical outcomes may be, but in terms of a business use case perspective,
Hmm.
how is the patient satisfaction? Is
Hmm.
this the one? Oh, willingness to recommend. I don't want the star one per se, but I want the ranking. So
Hmm.
let's drop that in here and just kind of, while we're on Berkshire Medical System, let's see. That's a great ranking. So
Hmm.
in terms of nurse communication,
Hmm.
let's drop the doctor one as well. So we'll see how that ranks. But the
Lower.
doctor
Yeah.
one, okay, so
Yeah.
there's a drastic contrast here. So that might be an insight
Yep.
if this was of value to you to look into, right? So the
Absolutely.
doctor communication, big disparity. The nurse communication, wonderful. So
Right. Right.
I have never been there, so I have nothing to say. And but
Right. I
but
have,
the,
but and I would concur, and some of the again, the rationale behind some of these numbers are you have to understand what's behind that. But certainly, as a if you were the head of the medical staff at Berkshire Medical Center, you might say, "Hey, folks, we've got to do a little better with doctor communication,
right,
even given the challenging environment and population of people that they're serving."
because some of these are controllable. You may not be able to
Hmm.
control the patients that walk through the door, but
Hmm.
you certainly more or less can control the type of care or
Hmm.
the service that goes into it. So or at least work on,
Yep.
right? So that this can give you an insight. It's up to you to apply the business use case and what you value this tool as.
Right.
But in terms of ranking how much discharge information, so sort of the care upon leaving on the information and how to take care of yourself or any directions, it's ranked 39. So not,
Mhm.
I would say there's definitely room for improvement. It's not awful, but it's definitely
Mhm.
not sort of middle of the road. It's slightly shy of that. So
Right.
same thing with willingness to recommend. That's not a great number. So I could definitely see just based on this, there's some room for improvement.
Yep.
Now, I'm sure if we went through this whole list, there's plenty of other positives here. So I don't want to make it sound, that anyone on the call will hopefully
Yeah.
never have to land there. That's not the case. That's not what we're trying to say. There's actually a lot of great folks we know from there, and they do a great job. So it doesn't paint a perfect picture. So you kind of have to take it with a grain of salt as well. But again, going back to the use
Right.
case, it gives you sort of the um, foundation and jumping block for where to start and where to look into these things in terms of strategic planning and the analysis. So
Mhm.
you know this coupled with the case mix, I would argue that that makes for a very strong data set tool
Mhm.
to start with
Right.
that.
Right. Yeah. I mean, obviously comparing, as we were talking about earlier, comparing the, essentially the market share numbers in a particular area against some of these outcomes, you could start to draw conclusions around where, resources and other activities need to be focused to continue to advance the health system forward. Yeah.
So I'm gonna go ahead and do a few different views as well. So now you've seen the custom dashboard. I don't want to kind of harp on this too much. You get a sense of what you could do, different measures that you could pull in and drag and drop. But what if you're not so savvy with Tableau, or this is sort of a little intimidating or daunting? So this is sort of the most extreme level, let's call it that you can go ahead and customize and slice and dice, right? So this is sort of the master chef level of this data. What if you don't necessarily want that and you want to go down to more of the Hello Fresh and say, okay, you just give me the ingredients. I just
Mhm.
want to know this. How do I do it? So let's go
Mhm.
from this to that. So I'll start with the bottom here. There's different tabs. So here, I'm just going to show you, this looks very similar to that. However, this is already preset, built with all of those measures already across the board. So you could go ahead and filter just upon here, and then it sort of is a shortcut. It's still in the custom setting, if you will, that you could go ahead and reassemble this how you want to and sort of kind of whittle this down to the view or report you want. So there's that. However, I'm just going to go ahead and move this aside. However, if you want to go up here and go into sort of well, you get timed out after 15 minutes as well. So
Mhm.
there's that too. But um, as long as you're being active in the system for into interval of 15 minutes, you will have that, and you can always save your work. But I went to in what's called sort of our summary or standard reports. Here, you could go ahead and have some sort of a less daunting, a more simplified view of things. So this is still outcomes. It has all of the different measures, still similar layout, and it gives you sort of a few simple different filters to go off of. So if you wanted to just kind of take the whole thing, but not chop it so finely, you could use it this way and go ahead and maybe you can, I don't know, if you want to go ahead and resort, you could do it this way and see, well, who's kind of at the bottom of the pack, vice versa, who's for different measures, who's at the top doing well in this category, this area. If you hover over them, they'll tell you what they are. So 30-day mortality, right? Brigham and Women's, Faulkner Hospital.
Number one. Mm.
Yep, Beth Israel Deacon. Is this the medical center or this is the Milton one? So this is the Milton one, number 4, and overall 16 in clinical outcomes, patient safety ranking 35, satisfaction 49. So there's room for improvement there, or something to be desired in the patient safety. So maybe something to look at, especially when the clinical outcomes are great. The overall outcome is great as well. Overall, it's a grade A for the overall, all 3 different main attributes that go into it: outcomes, value, and equity. But you can go down the list and kind of see all the different things that roll up into this, and maybe what is um, could be improved, or what's doing well that could be expanded upon, or even see what your neighboring hospital or competitor hospital is doing well and why, especially if you're seeing sort of the same um, patients demographics, right? So maybe if you were to be able to put some sort of level playing field, maybe it's not apples to apples, but if it's close enough to be apples and pears, maybe you could kind of use that as an inference. And then of course you see that you can do on the equity as well and value. So you can do that there. Another thing I'll point out too is that there is a heat map. Oh, actually, let me go to here since it's right here. You could look at this by different regions. So if you want to look at sort of the locality of it, you can go ahead and do this and zoom in here. It's a little bit tough because when you're out in the Berkshires, it's kind of not too much to zoom in on. It's just the nature of it, no pun intended there. But yeah, and of course the city is just so densely populated with a lot of the big names, right? Tufts Medical Center, Boston Medical Center, the Leahy. So but you get the idea here. Same thing. You can still sort these. You just sort of are able to filter out by view of geographic location as well. And then this is an interesting one that we're kind of still working on. And what I mean by that is working to make this improved. So right now we have this set up as this is measuring all of it, but let's go ahead and since we're talking about outcome, let's filter onto outcome. You can filter just select hospitals if you want, but right now, so all the hospital based on ranking outcome, or maybe we could do just maybe the Boston region and have a more simplistic view. But so you have number one, or who's leading in this category is Newton Wellesley Hospital, and then conversely you have, I'm gonna move this screen, you have Nantucket College Hospital. So that might be also the patient case mix locality there, but you could kind of see the other ones surrounding in sort of a visual representation of how they compare size. So each of these are to scale in terms of their value. The value is comprised on the back end. So there is a numerical value based on this that, obviously sort of kind of how the sausage is made. It's in the back end. And if you're curious about that at all, you can go into the Lown website and it will have for you the methodology here. So you could go ahead and see their white paper, how they do. You can download it and they'll tell you what their algorithm, not exactly what their algorithm, but at least their validation sampling and how they go about making sure that their data is accurate to the best degree possible. Oh, and actually, I should also mention, if you ever are wondering what some of these are, this sort of Lown Health page here breaks down exactly what the overall Lown data set comprises of. So tells you the different ranks. Some of them are with grade system, so grade A being best, just like in school or university. And then star, which is from CMS and Medicare. So, and then it also describes, for example, the weightedness of certain things that go into the ranking. So this goes back to the methodology, how each grade is ranked as well as weighted respectively. So yeah, so this is sort of the reference glossary guide, if you will. Any questions so far? I know we kind of dabbled in a lot here. We talked about a few different things. Is there anybody that has any questions or any certain interest in one topic or another? Oh, so I see some questions in the chat here. Good question,
Okay.
Stephanie. I don't know if we answered that, but so this, you can get some of the information on Lown. So if you go up to, I'm gonna move this, but if you go into their rankings, you can sort of see the very high level. So that is available publicly. So you can kind of go into it and drill down some of the hospitals. This is nationwide, so you would want to filter out into just Massachusetts, for example, and you could go at it this way. However, keep in mind you don't get nearly the sense of granularity or data from this. You kind of sort of have the overall arching rankings.
Yeah,
right?
the data file we get is all the detail down to that tier 4 level that Lynn was describing earlier, Stephanie.
Hmm.
And so you would have to get the data from them in order to do that. And we have an agreement with Lown to get the data. And that's how we're able to provide the views and the ability to slice and dice and look at different dimensions and measures within the data that way. Through
Yeah.
their website, it's a static view, as Lynn was just showing everyone. But and it only goes down to that third level of granularity on the website. But it's the same data.
Mhm.
If you compared the data, it should be,
Yeah.
essentially the same data. Yeah.
Right. So if you were to take what we were just looking at and sort of go up a few levels, higher level, then exactly the data would line up and match. Right.
Yeah. And
Right.
then to answer, Stephanie has a question.
The
Oh, okay.
next,
So, well,
yeah.
let's answer the question about Excel. So with our tool, you can download the data. So I don't know if you want to show how to do that, Lynn, or
So
not,
you
but
could, yeah.
yeah.
So for the case mix report, you could go ahead and download. Let me move this. The Zoom function always get in the way. So if you wanted to go ahead and not necessarily use this tool, or if you wanted to maybe populate this into a report or a PowerPoint, you could go ahead and do this. So some of you may be familiar with Tableau, and you can go ahead and choose to download this into such. And actually, a interesting thing, not necessarily giving away the data, but if you were to say take this data and sort of take all the possible data points that you were wanting to look at and filter, you could take this and download it into a CSV file and then do your own pivot table if you're more comfortable with that.
Right.
Um, so to answer your question, you can download it in other readable formats very easily. Yeah, in the Lown you can download it, but it won't give you. You can still download it in the purposes of embedding it into other file formats, but you won't be able to necessarily. You can still sort the data too. You can still definitely do that. So if you want to sort rankings, but it won't give you the sort of that second question there. It won't give you the exact value. So those are sort of hidden by design in this system,
Hmm.
the actual values. And I don't know exactly if it
Yeah.
would necessarily help you because it might be a value of 0.03456 something. It
Right.
doesn't necessarily give you much information. It's sort of back end information just for the system, if that answers your question. A link
Yeah,
to your tool.
it's all calculated using the analytics capabilities of the Lown
Yeah,
methodologies is how they do their actual numbers. So then they
right.
use that as a comparative index to relate to the other hospitals and other facilities within. It's really national. Their data is national, but we did just the Massachusetts data for the purposes of our Spotlight analytics. So it wouldn't be that meaningful, as to Lynn's point. It would just be a weird number, and you go, "What does that mean?" It's not like a percentage or something of that nature.
Mhm.
Um,
And I'm just put in the chat here if anyone is interested. Take a look at our website, and you can go ahead here and also at the very bottom if you want to kind of request to get information, download information. Please go ahead and feel free to. If you want to connect with us, you could do it this way, or you can just drop us a line here. I'll drop my email in here too. Um, although you may have it from Zoom, but I'll drop my email here as well. And this actually may be a good time to bring back up this so that way you do have it
mhm.
as well. So that's the one I want. So yeah, that's my information there as well as Dave. So feel free to reach out to us um, about anything. And actually,
Yeah,
I just
right.
thought
Yeah,
of some.
definitely.
Yeah.
Yeah, if anybody wants to do like an individual demo or to dive deeper into an area, we'd be happy to meet with you separately if that's easier for people.
And also, I think I just may have thought of something. So, Stephanie, maybe you're not referring to. No, no, you are referring to R2. Okay, but in case anyone that is interested, here is the you know, Lown's website as well. So, and it's already filtered on Massachusetts for you.
Yeah, to get access to our tool, you'd have to have a membership and sign an agreement with us just because
Yeah.
of the sort of the the sensitivity of the data and having confidentiality and all that.
Right.
So,
Exactly.
yeah, right.
But as mentioned, it's relatively simple, but you do have to sign an agreement, the data use agreement, making sure
Right.
that you're not a nefarious actor, you're going to treat this sensitive data responsibly.
Right.
So yeah,
Right. Right.
exactly.
Right.
Right. And then we'll kind of do all the back end work for you to stand it up, make sure it's working properly. Um, and even this tool is, I should mention this, so we have a unique case here where we actually recently had a organization who just came on as a subscribing member, and I won't necessarily put their name out there in public, but they want to look into some of the underlying factors that roll up into some of the cancer diagnoses. So rarely is that ever going to be the number one diagnosis, right? Not no one, but rarely are you ever going to be admitted to a hospital or a patient admitted to hospital and say, oh, it's because of cancer. No, it's probably going to be because of some other factor or disease or ICD-10 code, but the underlying cause may be cancer. So for that, we're actually creating sort of a custom, measure and flag for them. And that benefit actually is going to be expanded to others folks that use it too. So kind of what I'm trying to say is it enhances the usability for other folks as needs for others arise. So should one organization have a need for this, well, if it's worth it, then we'll go ahead and implement it so that everyone can use it to everybody's benefit. So this is sort of still a collaborative and health data centric community that we're still involved in. And we'd like to keep that growing. We are a not-for-profit, so hence the sliding pricing scale. We're not some of these big name companies that are either out there gouging you, etc. But yeah, that's my spiel.
Sounds good.
Uh,
All right.
any other questions? These are great so far. So let's see. Thanks, Stephanie. So, well, thank you all for joining and taking the time to spend out with us. Again, if you have any questions, feel free to reach out to us. This recording will be online on our YouTube page, along with some of the other work that we're doing. And just be on the lookout for some of our other events, other webinars coming up, and we'll do some more spotlight demos and deep dives on certain topics, I'm sure. So stay tuned.
Great.
All
Thanks,
right.
everyone.
Thanks, folks. Take care.